For those who don't know me, I'm Rahul Dwivedi. I'm the glaucoma clinical lead at Te Whatuora, Canterbury. I'm also the lead consultant ophthalmologist for glaucoma at Southern Eye and Christchurch Eye. I tend to mumble a lot, so if I'm not enunciating properly, just let me know and I'll try and shout a little bit louder. So when I was first asked to give this talk, the topic was something I thought quite hard about. I thought you've probably heard lots of stuff in the past about minimally invasive glaucoma surgery or lasers or angle closure, but very rarely do we ever stand up in front of an audience and talk about hypotony. And it's quite a strange topic because normally you associate people like me with high pressure, and high pressure is something which doesn't concern me. I don't mind high pressure, but hypotony is something which really concerns me because it's so difficult to get the patient seeing well again if they've gone hypotenuse, particularly after you've treated them. So I thought today would be a really good opportunity for me to talk to you about hypotony post-glaucoma surgery, how we recognise it, how we manage it, and probably more importantly, how for you guys to recognise it in the community and when should you be worried, if the pressure is below a certain value, should you be concerned, etc. So hopefully there will be some educational value to this talk. And it's not just some cathartic self-help sort of exercise. There are no financial disclosures. Okay, so what is hypotony? So the clinical and numerical terms tend to differ a little bit. So from a purely numerical side of things, we talk about hypotony being a pressure lower than 6 on 2 consecutive readings within a 3-month period post glaucoma surgery. Having said that though, I don't really worry about numerical hypotony. It doesn't matter if the pressure is 3, 4, 5, 6, as long as the eye is formed, as long as the retina is healthy, as long as the anterior chamber is deep, and as long as the patient can see, and see quite well, the number is completely irrelevant. So for me, it's clinical hypotony. And so clinical hypotony is something which has really bad or profound side effects and sequelae. So you get maculopathy, choroidal effusions, corneal edema, astigmatism, and cataract formation. So these are some of the bad things that can happen if you leave an eye with low pressure for too long. So when we talk about post-glaucoma surgery hypotony, it's actually quite prominent. It's actually quite common post-surgery. So the range in the literature is between 1 to 31%. That's huge. That's really, really a lot. I often say to my registrars that glaucoma surgery has the highest rate of complications afterwards, so you've got to be quite thick-skinned to do glaucoma, and especially if you want to operate on an eye. And it's not just about getting the pressure down, it's making sure it doesn't go too low. It's very easy to get the pressure down in an eye, you just stab the eye. But to try and make sure it doesn't go too low is quite a challenge. And for me as a surgeon, in most of my cases, I try and break down why the patient has gone hypotenuse, and it's usually due to 2 main factors. Either there's increased aqueous outflow, so the drain is draining too well, or there's decreased aqueous production, so the tap is suddenly just turned down. And so some of the most common causes for increased aqueous outflow, the most common is bleb leak. So with a trabeculectomy operation, for example, the conjunctiva hasn't healed very well towards the limbus, or the stitching isn't very good, and so the anterior flow of aqueous is much more prominent and it's leaking out of the bleb. Overfiltration, this is also quite common. So when you do a trabeculectomy particularly, the flap that you create, we want fluid to come out of there, but sometimes the fluid comes out a little bit too much and there's no resistance that's been built up behind the flap, and so there's just complete overflow of fluid. Tube surgery is much more common because you've got an unguarded wide board tube that's draining into the back of the eye. So overfiltration is another common reason. Cyclodialysis cleft formations, this is not as common, but it is probably becoming a little bit more common with minimally invasive glaucoma surgery such as goniotomies. Okay, so if you find that somebody's been doing a Cahook dual blade procedure or even eye stents and they're a bit too over-enthusiastic with the amount of viscoelastic they're using, or just a little bit misplaced with their goniotomy blades, they can actually cause a cleft. So both cyclodialysis and iridodialysis as well. So that's the other thing to think about. So that's where goniotomy can be quite useful. But I do understand in a soft eye, it's probably not what you want to be doing, but that's just something for us in secondary care to be thinking about. Then probably the most challenging type of hypotony can be due to uveitic glaucoma, and that's where the ciliary body and ciliary processes go into total shutdown and they just stop producing fluid. And that can be really difficult, and it's a really tricky condition to manage, and you just don't know when that ciliary body is going to start producing aqueous again. And anything which causes low pressure will mean that your ciliary body might start to detach as well, and it won't function as well, and it won't start to produce as much aqueous. So if you think in these broad-based terms, decreased production, increased outflow, those are usually the two big culprits for post-filtration surgery hypotony. So I thought, usually rather than talk about some didactic sort of textbook stuff, I'd rather go through some of the cases that I've had to deal with and inherited in my time over at the DHB. So one of the most challenging ones was Mr. PH, 68-year-old male, really complex ocular history. So congenital glaucoma, that's already ringing alarm bells whenever I see that. Biophthalmos, ringing another alarm bell because you know the scleral integrity is not as good. Dense amblyopia in the other eye. Bilateral penetrating keratoplasties, again, another alarm bell for me as a glaucoma surgeon. Seen my predecessor who valiantly tried to, deal with this only seeing eye and did a redo trabeculectomy about 5-6 years prior to me seeing him. And so the patient presents to the eye casualty in 2021 with reduced vision in his only eye and lots of pain and discomfort. He's already had movements in his right eye, we know that, but he's suddenly dropped down to 624, so he's not functioning at all. So he sees one of the acute senior registrars who finds that the pressure in the eye is 2 millimeters of mercury, and there's hypotony maculopathy that's quite prominent at the back of the eye. The findings that they describe, and this is quite important, that they say it's a supratemporal, thin cystic bleb with a central hole and a very brisk leak or Siedel's positive response. So I'm sure you're all aware, so with Siedel's positive response is you put some fluorescein over an area which you're suspecting is where the leak is going to happen, and you just observe and see whether or not that, with a cobalt blue filter, whether the dark green suddenly starts to become more and more brightly coloured and starts to flow a bit more. So when I tend to check for Siedel's in most of my patients, I don't tend to use the minim, I tend to use the fluorette. I think that's a lot more sensitive. I use the fluorette, put a little bit of oxybupropion or any local anaesthetic, and just gently paint over the bleb. And that's a really nice way of seeing whether or not you're going to get a brisk Siedel's leak, or even a very small microperforation can be identified with that technique rather than just squirting some fluorescein over, because by the time you get back onto the microscope or you're trying to adjust and look, the patient's already blinked, there's already a pool of fluorescein everywhere. Whereas this way you're visualizing directly where the bleb is and just gently painting over there with your fluorette. So the other important thing was that there was a central hole. Okay, so, and the reason why that's important is that the advice she was given by the on-call consultant would not work. So in the olden days, we'd say, try to introduce a bit of blood into the bleb. So you take some blood from the patient's arm, squirt it in there. That works relatively okay if you find that there's no major fibrosis or scarring happening on the edges of your bleb. But if you have a central hole, that's not going to work. So the reason why blood is useful at scarring down is it promotes fibroblasts. It promotes those healing sort of cells to try and do their magic, and you build this nice sort of, wall around the area where there's drainage. But if you've got a central hole in your bleb, the blood's not going to do anything. So unsurprisingly, a week later, the pressure is still 2, the bleb is leaking, no improvement in visual acuity, the patient's panicking now. So they asked me to have a look, and in these sort of cases, you've got to go in and you've got to repair this with a scleral patch graft. So these are stills from a video, and what I wanted to highlight here was that you can't really see it as well over here, but this really is the area of the leak. Okay, so you've got a very avascular looking bleb, quite an angry sort of inflamed bleb as well on the margins, and there's a leak there. This is real right front ophthalmitis, or a really bad blebitis case. So you have to go and get rid of this tissue to start off with. So the first thing I did was, rather than preserve conjunctiva, get rid of it. So that's necrotic. That's not going to be of any use. It's going to break down in the future as well. So snip away all of that, reflect it back. And what I can try and show you here is the outline of the original flap. So this was the redo trabeculectomy, and this is the flap here. So whenever I can, I try to restore the integrity of the flap by putting my releasable stitches in there. So I've put some nylon, non-absorbable, releasable stitches through there. But despite that, you can see over here, there's still a leak. So the flap itself is a little bit ragged. Okay, so there is still a persistent leak there. So if I bring conjunctiva back over there, we're going to end up with square one in a year. Okay, so you're going to leak again, the bleb's going to get thin again. So things that cause thin blebs, usually too much mitomycin. So we use antimetabolites like mitomycin, usually too much of it, too high a concentration or high dose. The other thing is anterior flow. So when I do a trabeculectomy flap, I want my flow to go this way, to go posterior. So I do quite a meticulous check to make sure there's no fluid leaking out the sides. If there is, that's going to promote anterior flow. If there's anterior flow, that contact of aqueous with the conjunctiva is going to make that conjunctiva thin, and you're going to get a breakdown in the integrity of your conjunctiva. So that's where you're going to leak. So some of these really thin-walled anterior cystic blebs you see in post-trabeculectomy patients is because there's too much anterior flow. Okay, so that's the other culprit. So if you see that sign, you've got to start thinking, I've got to try and patch this. Okay, so you get donor sclera and you put a patch over there so that all that aqueous that's going to gush out is not going to contact your conjunctiva. It's actually going to be forced back because you've patched that area and leave the back of the patch unguarded. So that's what I did. So I've got a scleral patch, so from a donor. And here, if you notice, what I've done is I've sealed the front, but I've left the back open. I've sealed the sides. Again, I don't want anterior flow. So I'm trying to encourage fluid to come backwards. Okay, so that's the idea there. Now, this guy who's had a couple of operations, and I've resected conjunctiva, it's really difficult to get that conjunctiva back over. So one of the things I do is do some relieving incisions at the back and relax the conjunctiva and tenons, then I'm able to make an advancement flap of the conjunctiva there. I don't mind a little bit of scleral patch graft showing. The conjunctiva will epithelialize over that, will grow over it, so it's not a problem, it's not an infection risk. The only thing it might just cause is a bit of Dellen sort of effect, so it might just cause a little bit of discomfort for the patient, so plenty of lubricating drops afterwards. If they're a contact lens wearer, then that becomes an issue as well. But usually I tend to shave this down, so this is how it looks, without having any treatment to it, but before I put the flap over, I would actually shave that front portion down so there's not as much Dellen effect. The other reason why I was going to talk about the central hole being quite important was that you're not going to get a BCL over there. So sometimes what happens is, you've got an early leak post-trab, it's leaking around here because your conjunctival sutures aren't too good or the conjunctiva is not healed very well. You can arrest that, with a bandage contact lens, give them a bit of atropine, reduce the steroid, and within a week or two, the healing process will occur and you can take the BCL out, and that's a conservative way of managing things. But there's no way a BCL is going to stretch all the way back there, and it's not going to do the job you want it to do. So that's just another reason why it's good to identify with your Sedell's test where the leak origin is, okay? So when I saw him last, 9th of January 2023, he's 14 months post-op, vision of 6/12, pressure of 11, looking quite healthy, quiet, no evidence of a leak, retina's flat. So that's a really good outcome for him. So really challenging case, quite a difficult operation, but 18 months or so on, he's pretty good. So this was one of a really difficult case as well. So sorry, these are slightly nightmare scenarios here. And again, I'm going to take my hats off to my predecessors and colleagues who actually dealt with this, because this was not an easy case when he came to them. So this is before I started at the DHB. Chap from Ashburton, pressures of 50 in both eyes. So the people who saw him in the DHB, the left eye is completely wiped out. His hand movements vision at best, a little bit of count fingers, with a push, but that was bad to begin with a pressure of 50. So my colleagues did sequential trabeculectomies on him, and unfortunately he drifted and his pressure never really recovered from the low single digits. He's a nervous guy. He's got lots of atopy as well. So he's just the complete car crash of a phenotype for you to deal with. So when I started, he then got referred to me for an opinion regarding post-trabeculectomy hypotony. He's a forklift driver, which is always another interesting thing, and he's been sacked from his job because they feel he's too dangerous to be around the construction sites. It's been a year since the trabeculectomy, so he had them in June 2020. He's come to me in May, I think, 2021, with that sort of ACT. So that's choroidal folds, that's hypotony maculopathy, that's just looking really sick. It's just a sick retina, you know, and it's just the integrity, the architectural aspects of the retina are completely disturbed there. So he's on a hiding to nothing. With most of my post-trabeculectomy hypotony cases, the key is to go in early, to go within 3 months. So I let it settle for a couple of weeks, try conservative management, but try and sort it out within 3 months. Don't leave it a year. Okay, so when I saw this patient, I wrote back to the physician saying, you know, it's his only eye, he's nervous, he's losing visual acuity, needs an urgent trabeculectomy revision with the scleral patch graft ready, because we don't know what the integrity of the flap is going to be. If it's within a month or two, your flap is fine. Go in, suture up, you're fine. If it's been a year or longer, that flap is going to be melting away, okay? So that's what we did. We did a similar procedure to the first chap you saw. So I'd gone in, did scleral patch graft for him, and this is now a while later. Vision is 6, 7.5, the pressure's 8. This is how we've got him on his subsequent OCTs, and this is where we've got his visual field. So that was pre-op, and this is a few months later, well, 18 months later. We've got him down to seeing very well. He's got his license again, so he's able to now go back to work. So these are really, you know, positive, life-affirming events. I mean, going back to work with a lot of sort of safety mirrors everywhere, and you know, all that kind of stuff. So, but that again, it just goes to show how somebody's life can be turned completely around. If you have that presence of mind, you know what you're going to be doing, you know what sort of strategies to have. So that was good. Right, so those were sort of trabeculectomy related hypotony events. Now we're going to talk about tubes. So this is a Baerveldt tube. So this is a Baerveldt 350. And what this tube is, it's an unvalved tube or an unguarded tube. So we put one of these in, we put the wings of the Baerveldt tube plate under the muscle, so usually into the superior rectus and lateral rectus. The tube itself goes into the anterior chamber through a sclerostomy. I tend to put a patch graft over there because otherwise it erodes through the conjunctiva. And what I then tend to do is put a supramid suture. This is Prolene, but I put a supramid suture as a stenting intraluminal suture through here, and I put a ligation suture around there because I'm so worried about Baerveldt tubes becoming hypotenuse. I try not to take a risk, so I'm belt and braces with a Baerveldt tube. So if ever you see any of my letters with a Baerveldt tube and you're thinking, what's that white stripe dangling, you know, under their subtenons or subconj area temporally, that's probably a little bit of the supramid that I left hanging there in subtenons, so that if ever I do need to remove it at the slit lamp, I can make a nick through the conjunctinons and pull it out if I need to. Okay, so that's what a white sort of line temporally will be. It's the supramid suture. So usually what we do with a Baerveldt tube is we keep the pressure high. So, you know, day 1, week 2, week 3, the pressure is going to be pretty much identical to what they had before the operation. But we manage it with Diamox and drops, and so there's no material difference to the patient for their burden of aftercare. It's still the same drops, same Diamox. And the reason why we do that is if we try to get rid of this suture early on, the flow is going to be so profound and there's not enough resistance and scar tissue built up over the back, you're going to go hypotenuse straight away. Okay, so that's the idea behind a Baerveldt tube. And then usually around 3 months is when I start to remove the suture if needed. If they don't need to remove the suture and they have really low pressure and you're happy with how things are, then leave it in. Okay, you don't have to remove it. So this is one of my overfiltration cases from a tube. So probably one of my most difficult cases I've got, and this is just an absolute nightmare. Again, something I inherited quite late on. So 38-year-old ICU nurse, another massive risk factor. So risk factors usually include relative of a friend, and then any sort of allied healthcare professionals, the other big risk. especially when they're in ICU. So you know that the stakes are high because we're struggling to have nurses in most of our units in the hospital. So very complex ocular history. So Filipino, severe juvenile open-angle glaucoma, diagnosed age 18. Presenting IOP is 50, maximum IOP 60. Bilateral SLT, bilateral trabeculectomy in the Philippines, age 19. So she's had quite a lot within a year of being diagnosed. Didn't work, which is not very surprising. So most congenital or juvenile glaucomas, trabeculectomies don't really work that well for them. So it's often a good idea to go straight with the tube. So she had a right eye redo trabeculectomy in November 2019, again before I started, so this is in Christchurch. Then had subsequent needlings, and then finally came under my care in early 2021. So at that stage, I said to her, you know, your vision's not brilliant, your pressure's quite high, your fields aren't very good, so if I stick a knife in the eye, I'm on hiding to nothing. You're going to snuff out, you're going to lose whatever field you have, and it's not going to be pretty, and it's not going to be good for either you or me. So let's try micropulse cyclodiode laser. So let's turn your tap down, because this is theoretically less pro-inflammatory, it's a little bit safer than the conventional diodes, and you know, it gives us a bit of time, we can repeat it as well. So she did all right to start off with, she wasn't too bad. And then she came back in May and she said, my pressure's gone up again. And I think it's somewhere around 20, so it wasn't anything major, but it was too high for her. So we said, that's fine, let's do your micropulse again. And we got a bit greedy. We said, let's up the energy setting a little bit. Let's try and get you a little bit longer, you know, a few more months. And then bang, a couple of weeks later, she comes back with excruciating pain, pressure of 40, post-diode laser inflammation. So we had no option, so I had to go in and do a Bearvelt tube. And so because she's somebody who's had previous surgery, she's an Asian ethnicity, she's going to be scarring quite prominently, she's got inflammation, I tend to increase my mitomycin dose to slightly higher than my usual trabeculectomy doses. So we said, right, let's do that. And so this is, again, is a still from one of my videos. So you've seen the Bearvelt tubes, that's underneath the muscles, there's a bit of conjunctiva that I've put over it. I've secured the plate with some 9-0 nylon sutures, they're non-absorbable. I've put a supramid suture down there, and I've also put a ligation suture over there, and I've tacked the tube down with some just nylon sutures, so box sutures. And I tend to do a slightly like an S-bend sort of approach into the eye because it offers me relative pinch points to stop the pressure going too low. So rather than going straight with a radial approach, I'll tend to make an S-bend approach there. So far so good, pretty easy going surgery, wasn't too difficult. And so I see her 2 weeks after. Vision's not great. The bleb's completely flat, as expected, okay, because remember, we've really ligated everything. We've put a supramid in there. We're not expecting flow. AC's okay, a little bit of inflammation, tube's sitting well. So I'm not too fussed. But the problem is the pressure's 38. So it's difficult to justify leaving a pressure of 38 to a patient who's on the doorstep of being blind, and when the pressure was pretty much that to start off with, it's quite difficult to convince them that it's a good idea to hold fire. So she was really anxious, her partner's really anxious, and they said, do something, we're on maximum Diamox, we can tolerate maximum drops. So begrudgingly, I went against every bit of sort of training that I've had and went for an early removal of supramid at the slit lamp. So I felt a little bit sort of swayed by the patient there. And I said to her, stop your IP lowering drops and Diamox, continue with your normal post-op steroid and antibiotics, and I'll see you in a week or so. Anyway, 4 days later, she comes into the acutes. Vision of hand movements. So diffuse bleb, so bleb's really good. Cornea's now got Bowman folds, so you've all heard of Desimo's folds, but there's also Bowman's folds, which is what we get in hypotony, and I'll show you a picture of that later on. AC's shallow, not yet developing iridocorneal touch, but it's well on the way there if we leave it alone. The tube tip is in contact with the lens, and this is a phakic eye. So this is horrible. There's just inflammatory material everywhere. The lens is rubbing against the tube. She's in hysterics, it's around the eye, and it's going downhill very quickly, and the pressure's 3. So I look at the macula, lots of folds, the solitary hemorrhage there, inferior choroidal. So this isn't looking very good. So hypotony maculopathy post-tube is the diagnosis here. So what I do in this instance, for a tube at least, is I put some Helon into the anterior chamber. So I wouldn't really do that with a trab. It wouldn't really work because a lot of the Helon either will get shifted towards the ostium and probably migrate and escape. But usually with a tube, once you put a Helon injection into the AC and volumize the AC, it stays there for a few days, buys you a bit of time, and often it's more than enough. So with this patient at the slit lamp, she's not feeling great. I'm not feeling great. We put a bit of Helon in there, and pretty happy. Reduce the steroid. So the reason why I reduce the steroid is to promote healing. So if I get healing behind where the tube is flowing, then I can try and provide some resistance to flow, and then the pressure builds up. The other thing I tend to do is start some atropine. So anybody who goes hypotenuse post-op, I'll put them on a bit of atropine, and the atropine just encourages the ciliary body to just kickstart and produce a bit more fluid, and so deepens the AC, just gives you a bit of time as well, dilates the pupil. So those things, we put all those conservative measures in place. And this is what she was like post-injection. So pre-injection, you can barely see, it's a really poor quality scan. That's really because of all that inflammatory material and stuff from the lens. AC is not very good, the cornea is not very good, so you can't get a good view. And this is just a few days later. So remember, that was, what date did we see her? 2nd of August. And this is 25th of August, so just a couple of weeks later. Really good integrity of the macula there. So those folds have completely gone. And this is what Bowman's folds are. So DM folds, sorry, I don't think this is showing up as well as it normally does, but I'm pretty certain most of you have seen our post-op desmoid membrane folds and things with our cataract patients who haven't turned out too well. And it's a little bit deeper, and it's quite striking, those DM folds, whereas the Bowman folds are a little bit more anterior, a bit more superficial. They're a little bit more wavy. Okay, so usually always vertical, and they're a little bit wavy as well. So that's usually a sign of hypotony. So then I saw her a year later. Vision's better than what it was. So remember, she was 695 before the operation, pressure's 12. She's off her Diamox now, on maximum medical therapy, but her OCT now is looking pretty good. So she's doing quite well. She's back to work as a nurse, that's good. But yeah, definitely lost a lot of sleep over that case. So that was a good outcome for her. This is another one that's kept me awake. Probably made my hair go a bit whiter since I've been here. So this is a patient who Alan Simpson had under his care, and then Alan, as a nice little gift, sent it to me in public to try and sort it out. So he's a gentleman who's quite young, I think he's only in his 50s, really florid pseudoexfoliation glaucoma in his eye, presented to Alan with a pressure of 42. Alan had done some SLT on him, but every time the pressure would go down, within a matter of a month or two, it'd go back up. Again, really good cataract surgery, and so he came to me, and we had no option. Pressure was 40 plus. Did a trab in May 2021. But it was weird. He's just somebody who aggressively heals. So he was going the other way. His pressure just kept shooting up. Tried to needle him, and every time I tried to needle him in clinic, he'd collapse, and he had some defibrillating sort of weird sort of heart thing going on. So he'd collapse and start seizing. So I thought, right, I can't needle him because I'm really poor with my CPR at the moment. It was the least of my worries, so I'm more worried about this bleb. So then I decided, right, let's take you back to theatre, let's do a proper needling with some proper anaesthesia, with an anaesthetist around. And we did, and it worked really well for a couple of weeks. And then 3 weeks post-needling, the pressure goes to 55, he's in pain, he's nauseous, he's crying, his wife is crying, I'm about to cry. And then usually when you have a trabeculectomy which just isn't settling, normally this is quite early. So a month post-trab, it's quite early to throw in the towel and do a tube. But the way he was healing was just so weird. It was just so aggressive that you would have thought, do you know what, doing another trab or another needling isn't going to work. So it's not going to be a long-term solution. Whereas doing a tube would be a better long-term solution. So we decided to, again, do a Bearvelt tube, similar dose of mitomycin C, and have a scleral patch graft. So I did that for him a month later. And again, this is another still from my videos. This is what a Bearvelt tube looks like. It's actually quite big. So the plate is quite big. And again, these wings slide under the muscles. so superior lateral rectus. And if you can see this white sort of line coming out, that's your supraumid suture. So that's your intraluminal stent suture. So that's just to give you an idea about, how it looks. So what did we find? So normally I'll always make sure my op notes are quite well detailed, so I know if I have to ever go back, I know exactly what I did, what sutures I've put in. And so I put the supraumid suture partway down the tube. Again, that's the belt. I put the ligation suture around the distal end of the supraumid, that's the braces. So, really made sure that there's no flow, squirted a bit of, fluid, made sure there's no flow, and everything else pretty straightforward. So again, straightforward case, not an issue. Because he's somebody who's never had that low pressure, and I didn't want him to continue to go through 6 weeks of pain and nausea with pressures in the 50s, I decided to do what's called a vicryl wick suture, where if I go back to my tube, if you've got this portion of the tube into the AC, your supraumid is going to end about here, and your ligation suture is just in front, so you've really pinched your tube. No flow is going to happen. But if you want low flow early on, I'll put a releasable stitch which goes through the cornea, and then I transect the tube with that needle of that stitch, go through the tube, cut the needle off, and leave that suture there, and that will provoke a little bit of beading coming out of that tube. It's like a Sherwood slit, right? But again, it's a bit more controlled, because if the pressure goes too low, I can get at it at the slit lamp, I can pull it out, I can release it, and then the tube just goes back to normal again. So because I wanted early low pressure for this patient, I decided to put a vicryl wick suture in there. And so I saw him a couple of weeks later, pain last night, comes in with vision of hand movements, shallow AC, no iridocorneal touch, he's got a high femur, tube sitting well, no endothelial or iris touch. Pressure of 4, but he's got large kissing choroidals. So again, he's great candidate for a suprachoroidal hemorrhage here if I leave him the way he is. So he's got post-tube hypotony. So what do we do? Well, get rid of the wick suture. We don't need that anymore. His pressure's quite low. And remember the former case, let's put a bit of Helon into the AC, which is fine. So managed to do that for him. So 5th of November, 3 months post-Beervelt tube. Not too bad, actually. Pressure, vision 69.5, pressure 23. And so I thought 3 months post-tube, we're fine. Let's take that supraumid out. He'll be great. Took the supraumid out, and straight away, as I pulled it out, just the horror, just watching just in front of you, the bleb just expand massively, and I was like, oh, for goodness sake! And so, I said, look, you'll be fine. Stop your Diamox, stop everything. I'll have a look at you in a week or so. And then he comes back 10 days later, and he's like, look, my vision's gone from pretty good to pretty bad. It's quite hazy. 6:30, really good bleb, so the tube's flowing quite nicely. Shallow AC, tube sitting well, but the pressure's now 3. Large kissing choroidals and maculopathy, so here we go again. What do we do? Well, the Helon works quite well, but let's do that again. So again, inject some Helon into there, repeating some of our previous things. But then these are the choroidals. These are huge, right? And this is not a great thing to just sit on. So 4 weeks after we removed the supraumid suture, and a couple of weeks after the Helon, the pressure's still 3, choroidals pretty much present in 3 quadrants. So I said, right, he's gonna lose the eye here if we do nothing. So let's take him back to theatre. So when you take a tube back to theatre, try and reduce the risk of hypotony or treat hypotony, what you do is you do ligation sutures. So you make a posterior incision. So if I go back again to my sort of diagram over here, basically the tube will be sitting a bit further back, and so you don't touch anything at the front, so your patch graft is just staying where it is. I try and find this area of the tube, which is slightly visible beyond the patch. I make an incision through conj and a separate incision through tenons, because there's a tenons capsule that you don't want to affect. Find this bit of dissect down to this bit of the tube. Then I put about 3 or 4 sutures around there, preferably nylon, so that if the pressure goes up again, I can get at it with a laser. So with a lens and laser in the clinic. So that's a technique that I tend to use. So 3 or 4 nylon sutures of varying strength and various tightness. And then I just laser the tightest one first and see if it holds, and then just do that sequentially. So that's one of the techniques that I tend to use to revise those tubes. So that's what we did. So we put 4 ligation sutures, 9/0 nylon, and pretty routine sort of stuff. So that's good. So he's 1 month post-tube revision, and vision of 615, which is way better than what it was before. Pressure of 25, so it's still too high. So then what did I do? I lasered one of the sutures, told him to stop his pressure-lowering medication, but as in Diamox, but continuous drops. And then last we saw him, so March 2023, 18 months post, Bevel tube and revision, vision of 6, 7.5, pressure of 9, no longer on drops, no longer on tablets. He's gone from this back in November to this. So really good outcome for him as well. So that's just an example of when the Helon doesn't work, you've got to be a bit bold and go and do a proper revision there. So the reason I've included this picture is because more and more of you are going to be seeing my letters coming back with Ahmed glaucoma valve written in them. And this is a tube that I trained with in Liverpool. So Bevelts I really got to train with in Auckland, and a little bit in Manchester, but Ahmed was what I used in Liverpool. And Ahmed, we really liked the Ahmed valve because it's got a valve in there. So you can't go too low with your pressure. Having said that though, your pressure doesn't go as low with a Bevelt. So these tubes are fantastic for patients with neovascular or uveitic glaucomas or pressures of 50, where you just want them to be in the 20s or low teens on one agent. These are great, low risk, not a problem. If you've got a patient with a pressure of 20 who's had a previous trab and they need a pressure of 10, you need to put a Bevelt in. So that's where the 2 tubes differ. So if ever you're wondering, looking at my letters, why did you do an Ahmed valve for this patient? Why did you do a Bevelt valve for this patient, or Bevelt tube, sorry? That's the reason why. And often I choose this valve for some of my rural patients as well. So if you're a West Coast patient, if you're from Southland or Otago, somewhere that you can see me, I'll put one of these in because you can't guarantee those weekly visits as well. So there's less fiddling about, less removal of supramid, so you don't put any stent sutures in there. I don't ligate this tube either. I just rely on the internal valve. So here you can see me, this is a still from my video. I'm actually priming the valve. So I'm squirting a bit of BSS in there and it's making sure the valve is functioning. Okay, so that's a big drop of fluid there. This is a bit chunkier and a bit thicker than the Bevelt, but again, it's not too badly tolerated. So that's just the Ahmed valve. Right, so this is the nightmare scenario. This is decreased. So those weren't too bad. This is a nightmare because what happens when the tap stops? Well, what do you do? So if the tap has stopped, this is really bad. Okay, so I've got a really difficult patient and 45-year-old male. So the younger they are, the more anxious they are. There's more at stake. There's the jobs. There's driving. There's quality of life activities, relationships, and all this kind of stuff at fault because they're just a complete mess, right? So this patient gets sent to me by my uveitic specialist colleagues because they're at their wit's end because they can't control his uveitic glaucoma. He has inflammatory issues that aren't being controlled on really high-end immunosuppressants. He's on maximum medical therapy. Steroids also make the pressure go up. So what do we do? Well, in the olden days, about 10 years ago, the thought process was tube uveitic, okay? Otherwise, the trabeculectomy area is going to scar down, too much inflammation. But that's not the case. If you immunosuppress somebody properly, trab them first. So if you trab somebody first, in most of my uveitics, trabs work really well, and then you give yourself enough room to put a tube in later, if for whatever reason, 10 years later, the trab stops working. So always trab first with the uveitic now, that's the thought process, and then you can tube them. So that's what I did. I listed the patient for a trabeculectomy, standard MMC dose for a uveitic, and also subtenon's triamcinolone, so an extra bit of steroid bolus in there because we don't want them aggressively scarring. And then this happened. So really happy. Day 1, pressure of 9, week 1, pressure of 8, vision 6.5, week 2, feeling amazing. Pressure of 7, 6.5. How good is that? That's the best outcome. Week 3, pressure of 5, 6.6. Not fussed because numerically that's a little bit low, but clinically he's amazing. Week 4, pressure of 6, vision of 6.6, absolutely fine, not worried. Reduce your pred fort now, I'm pretty happy. Week 8, so 2 months post-op, things start just going a little bit haywire here. So pressure goes to 3, vision goes to 6.12, stop the steroid, encourage healing. Okay, so stop the steroid, start the atropine. So at this stage, we're thinking that it's overflow. Okay, we're still thinking it's overflow. It's got a diffuse bleb. So stop the steroid, encourage healing, bit of atropine, you should be fine. I then go away to the UK a couple of weeks later, which always happens. The patient comes in, pressure of 2, 6.15. They actually texted me about this, and I said, look, it's most likely going to be a shutdown, ciliary body shutdown. So the tap in the uveitic has now started to just completely turn off. So with the ciliary body shutdown, what you should do is go the other way with your steroid. So give them a steroid challenge. So really kickstart that ciliary body into producing fluid, and you do that by putting them on hourly steroid. Okay, so restarted the pred fort. I'll be back in a week or 2, and we'll see the patient. By the time the patient comes back to see me, it's 4 months post-op, pressure of 3, vision's really gone downhill now, 6/120. So because he's still within that 4 month, 3 or 4 month sort of time zone, I know that if I take him back to theatre, he should have a pretty good flap. I know that he's probably not overflowing, it's mainly a ciliary body shutdown, so I'll probably just need to go and tighten some stitches and just make sure that flap's just, behaving, and that was it. Didn't really think much more beyond that. So for you guys in the community, if you've got a uveitic, even if it's not post-op, even if it's a standard uveitic, and you're starting to see this picture, that's ciliary body shutdown. Okay, so it's this gradual decline over weeks and months. That means the ciliary body's not working. So if that's the case and that's dangerous, you've got to really up the steroid. Okay, so that's just something for you to, don't do what I did and start celebrating around here. Actually think what's going on, and you can alert us to it or increase the steroid dose. Okay. So this is what the ACT looked like. So VA of 6/120, and that's the reason why. So what did I do? So I explored the trabeculectomy site. The flap had good integrity, so it wasn't ragged, it wasn't leaking with sort of perforations in there. I removed his nasal releasable sutures. So what I tend to do is do a trabeculectomy with lots of releasable sutures, and that gives me the ability to adjust them at the post-operative visits. And so I release the tension on those stitches, but I leave them in if the pressure is very good. And if the pressure is too high, I can release them. So it just gives me a little bit more control than the North American style technique, which is fixed sutures, which you can laser afterwards. Because once you laser them, you lose control. Okay, so I removed my nasal releasable and I replaced it with a fixed nylon suture because I just wanted a little bit more security there. I put an extra central releasable suture in there as well, and I tightened the original temporal releasable. So lots of tightening going on. Okay, that's pretty much it. I use what's called an AC maintainer. That's an infusion line into the anterior chamber, so the eye stays firm. So if ever you try and operate on a soft eye, it's horrible. Okay, your stitches aren't, your needle's not passing very well through the sclera. Stitching is a real big challenge. So I try to firm up the eye with an infusion line, and that just gives me also an idea about how much that flap is able to withstand physiological flow and artificial flow as well. So here's a video of me putting that central releasable suture here. So I make a pass through the cornea and then go back through. So it's like a loop, which I can pull out if I need to. I then go through my trabeculectomy flap, and then I go through the wall of the sclera. So I've speeded this up, I'm not this fast. Okay. It's getting a little bit boring for me to watch. That's my infusion line. Okay, so that's keeping the eye nice and hard. So as I pull this out, what you can see me do is my releasable, and for this, it's a slightly different technique to how you normally would suture an eye, and I sort of leave like a little bow tie sort of technique. So I leave that as it is, cut the end there. But here what I'm doing is I'm looking at flow. So I'm really focusing here, turning the AC infusion on and off, checking to see where the flow is coming from, and then seeing whether or not this will hold under physiological conditions. And if it's not, then I go back and tighten. So this is how I titrate my sutures and how I get an idea about whether the patient will be able to have a good integrity of their flap, whether it will stay nice and tight, or whether I need to put an extra stitch in. Okay, so That's what I'm trying to test over here. So on, off, so I'm telling my registrar on, off with the AC maintainer, and we're having a look over here. So that's pretty much how I do a releasable suture for my trabeculectomy flaps. I don't think there's anything exciting in this video apart from that, so I'll probably go ahead. So yeah, so a month after the revision, pressure is 17, VA 6.6. 2 months after, pressure's 13, VA 6.6. I'm getting a little bit worried because I'm thinking this reminds me of something. But on the whole, he's been pretty good. And so this is what his pre-op ACT was like. This is his post-op. I mean, that's beautiful. It's completely restored the integrity of his RPE and the rest of the retinal layers. This was his visual field before. So this is a chap who's also got some neurological issues as well. So he's got some weird brain stuff going on. So that quadrantenopia that you're seeing, he's got a similar thing going on in the other eye, and that's due to the brain issue. But really, it's this bit I'm looking at over here, and that's a little bit better. So it's not worse. So he's not lost vision. He's not lost field. So that was good. That was a good outcome. So really, what I want to try and highlight with this talk was that you're going to be seeing a lot of post-glaucoma surgery patients going through your practices. A lot of them will have low pressure, and it's when do you panic? So if the pressure is 3 or 4, but the eye looks great, AC is deep, vision is better than 6.9, there's no macular folds, your ACT looks pretty good, pretty uniform, there's no detachments you can see, leave it alone, don't worry, nothing to worry about, because that's numerical hypotony, it's not clinically worrisome. But if it is clinical hypotony, so those choroidals that we saw, shallow AC, really diffuse bleb, those sort of things, you've got to be on guard, because that could be something, the earlier we deal with it, the better the outcome. For the uveitis, you've got to understand what the mechanism is. Is it overflow or is it shut down? Because we might not see them. We might say, you're doing so well, month 1, we'll see you in a month, and with the way our clinics are, it might be 2 months. And in that time, they might have come to see you because their vision's gone a bit blurry, and you might be able to see the trend of those pressures. So that's just something to look out for uveitis, okay, the shutdown mechanism. But vast majority of the time, it's the overflow, okay. Hopefully, you've seen different tubes, so you'll come across Bearvelts and Ahmeds. If you see my patients, some of my colleagues will do Multinos. I don't tend to do them, but you'll see those hanging around. Similar sort of tube thing as well. So as long as you sort of know what the differences are between the two, it'll give you an idea about where to expect the pressure to be and at what stage. And something I try to focus on, and I've done it a lot at the DHB, is try to get auditing going with our post-operative results. So I do the audit meetings. I'm clinical governance lead as well. So try and encourage the surgeons to re-audit. Is what you're doing working? Is it safe? And is it adhering to international standards? So one of the really good websites to go on is in Boston, it's the Massachusetts Eye and Ear Hospital, and they publicly publish all their surgeons' results on a yearly basis, or every couple of years. And so they're usually held as quite a gold standard for post-op complications and revision rates. So for them, within 6 months of trabeculectomy surgery, they've got a revision rate of 12% and a tube rate, revision rate of 14 to 15%. Fortunately for me, mine's hovering around 5 to 6%. But you've seen with a lot of them, it's quite a scary situation. And I keep saying, glaucoma surgery is the highest rate of postoperative complications, so out of all the specialities. I keep reminding my VR colleagues about this, who seem to be stressed all the time. Their issue is nothing compared to ours. So even if you do an identical operation on 2 different patients, you might get completely different outcomes, and you've got to have a thick skin, because otherwise you won't be able to sleep at night. But then you've also got to educate yourself and think, how can I make my surgery safer? How can I stop this from happening? So I say to my registrars all the time, I don't mind high pressure. Keep things tight, keep the flap tight, keep the tube nicely tightly ligated. High pressure, easy to deal with, okay? Medications, Diamox, take them back to theatre if you need to, but you can always bring it down. Low pressure is a problem. Low pressure is something that's never talked about, and it's something which will blind you. And if you leave an eye with low pressure, eventually you'll get a choroidal hemorrhage. You'll get suprachoroidal hemorrhage, you'll lose sight forever. Okay, so you've got to be really careful about when to go in and when to operate as well. But one of the things I'm trying to do now is to stop me from getting to this stage. So how can I delay trabeculectomies? How can I delay tube treatments? And that's to prevent them from happening in the first place and manage these glaucoma cases better, intervene early. SLT, MIGS. MIGS is a much safer alternative. Fair enough, it might not be suitable for all patients, it might not get the desired pressure lowering effect, but if you catch them early enough and you intervene early enough, they might not need a trabeculectomy 5 years down or 10 years down the line. Try to go with valved tubes if you're really worried about hypotony, if it's a really high myope or they're a uveitic, they live far away, they might not be able to make their appointments. Think about a valved tube. The other thing I say to my registrars is operate with an infusion line in the eye. It gives you much more detail about how the integrity of your flap is, how well it's functioning, how much to tighten your stitches, but also it makes life easy. You stitch better, your incisions are better when the eye is firm. Okay, so that's just really something for me and the registrars and the fellows to be mindful of. But yeah, I thought I'd share some nightmare cases and hopefully that's provided some form of entertainment and education, probably at my expense. It's all good. Thank you very much.